Now, are you able to see?
Yes, sir, we can able to see chest X-rays for undergraduates.
Chetan sir.
ನಮಸ್ತೆ ಎಲ್ಲರಿಗೂ ಕೇಳಿಸ್ತಾ ಇದೀನಾ ಈಗ?
Yes sir.
ಓಕೆ. ಸೊ ಎಷ್ಟು ಜನ ಜಾಯಿನ್ ಆಗಿದ್ದೀರಾ ಟೋಟಲ್?
24 sir.
24. ಓಕೆ. ಸೊ ನಾನು ಕಾಣಿಸ್ತಾ ಇದ್ದೀನಾ ಎಲ್ಲರದು ನಮ್ದು ವಿಡಿಯೋ?
Okay sir, clear.
ಎಲ್ಲರಿಗೂ ಕ್ಲಿಯರ್ ಇದೆಯಾ? ಆಲ್ 24 ಸ್ಟೂಡೆಂಟ್ಸ್ ವಿಡಿಯೋ ಆಡಿಯೋ ಬೋತ್ ಒಂದ್ಸಲ ಕನ್ಫರ್ಮ್ ಕೊಟ್ರೆ ಸ್ಟಾರ್ಟ್ ಮಾಡಬಹುದು.
Yes sir, we are
Yes,
able to
sir.
see you as well as slides.
ಓಕೆ, ಥ್ಯಾಂಕ್ ಯು
Sir.
ಸೊ ಇವತ್ತಿನ ಕ್ಲಾಸ್ ಬಂದು ಚೆಸ್ಟ್ ಎಕ್ಸ್ರೇ ಬಗ್ಗೆ ಇರೋದು. ಸೊ we know that it's a basic part of interpretation, as a basic test in the practice, because it's a basic test even for the general health checkup. It's a basic testing in emergency, OPD and everywhere, I see. So to know the basics of chest X-ray, we must have some systematic approach in that. ಅಂದ್ರೆ ಒಂದು ಎಕ್ಸ್ರೇ ನೋಡ್ಬೇಕಾದ್ರೆ ನಾವು ಏನೇನು ಪರಿಗಣನೆಗೆ ತಗೋಬೇಕು, ಯಾವಾಗಿಂದ ಏನೇನು ಅಂಶಗಳನ್ನ ಗಮನಿಸ್ಬೇಕು, ಒಂದು ಎಕ್ಸ್ಪೋಜರ್ ಇರ್ಬೋದು, ರೊಟೇಷನ್ ಇರ್ಬೋದು, ಕ್ವಾಲಿಟಿ ಇರ್ಬೋದು, ಹಾಗೆ ಮತ್ತೆ ಅದರದ್ದು ಇಂಟರ್ಪ್ರಿಟೇಷನ್ ಇರ್ಬೋದು. ಡೋರ್ ಓಪನ್ ಕರ್, ಎಕ್ಸ್ಕ್ಯೂಸ್ ಮೀ, ಡೋರ್ ಓಪನ್ ಫಾರ್ ನೆಟ್ವರ್ಕ್ ಆನ್ಲೈನ್. ಚೇರ್ ರಕ್ದು ಮ್ಯಾಮ್, ಒಂದ್ ನಿಮಿಷ, ಸಾರಿ ಸ್ವಲ್ಪ ನೆಟ್ವರ್ಕ್ ಇತ್ತು. ಸೊ ಎಕ್ಸ್ರೇ ಬೇಸಿಕ್ ಅಪ್ರೋಚ್ ಹೇಗ್ ಮಾಡೋದು ಅಂತೆಲ್ಲ ನೋಡೋಣ ಇವತ್ತು. ಓಕೆ, ನೆಕ್ಸ್ಟ್ ಸ್ಲೈಡ್ ಹೆಂಗ್ ಮೂವ್ ಮಾಡೋದು ಇಲ್ಲಿ? ಹಲೋ, ನೆಕ್ಸ್ಟ್ ಸ್ಲೈಡ್ ಹೇಗೆ ಮೂವ್ ಮಾಡೋದು? ಇಲ್ಲಿ ಆಪ್ಷನ್ ಹೇಗಿದೆ
ಸರ್ ಹೇಳ್ತಾ ಹೋದ್ರೆ ನೆಕ್ಸ್ಟ್ ಸ್ಲೈಡ್ ನಾನು ಮೂವ್ ಮಾಡ್ತೀನಿ ಸರ್ ಇಲ್ಲಿ.
ಓಕೆ, ನೆಕ್ಸ್ಟ್ ಸ್ಲೈಡ್ ಹೋಗಿ. ಎಸ್, ಸೆಕೆಂಡ್ ಸ್ಲೈಡ್.
ನೆಕ್ಸ್ಟ್
ಸೊ ರೇಡಿಯೋಗ್ರಾಫಿಕ್ ಡೆನ್ಸಿಟೀಸ್ ಬಂದು ಏರ್ ಹೇಗ್ ಕಾಣುತ್ತೆ? ಫುಲ್ ಬ್ಲ್ಯಾಕಿಶ್. ಸೊ ಮೆಟಲ್ ಬರ್ತಾ ಬರ್ತಾ ವೈಟ್ ಆಗುತ್ತೆ. ಅಂದ್ರೆ ಲೆಸ್ ಒಪೇಕ್ ಇಂದ ಹಿಡಿದು ಹೈ ಒಪೇಕ್, ನಿಮ್ಗೆ ಲೆಫ್ಟ್ ಸೈಡ್ ಇಂದ ಲೆಸ್ ಒಪೇಕ್ ಇಂದ ಹಿಡಿದು ರೈಟ್ ಸೈಡ್ ವರೆಗೂ ಹೈ ಒಪೇಕ್, ಆ ಇನ್ಕ್ರೀಸಿಂಗ್ ಆರ್ಡರ್ ನಲ್ಲಿ ನಿಮ್ಗೆ ಕಾಣ್ಬೋದು. ಏರ್ ಇದೆ, ಫ್ಯಾಟ್ ಇದೆ, ಸಾಫ್ಟ್ ಟಿಶ್ಯೂ ಇದೆ, ಬೋನ್ ಇದೆ, ಮೆಟಲ್ ಇದೆ. ಓಕೆ, ಸೊ ಯಾವ್ಯಾವ ಟಿಶ್ಯೂ ಯಾವ್ಯಾವ ತರ ಕಾಣುತ್ತೆ ಅಂತ ನಿಮ್ಗೆ ಇದಾಗುತ್ತೆ. ಸೊ ಲಂಗ್ಸ್ ಅಲ್ಲಿ ಬೇಸಿಕ್ಲಿ ಗಾಳಿ ತುಂಬಿರೋದು. ಲಂಗ್ಸ್ ಬೇಸಿಕ್ಲಿ ಏನು ರೆಸ್ಪಿರೇಷನ್ ಆರ್ಗನ್. ಸೊ ಗಾಳಿ ತುಂಬಿರೋದ್ರಿಂದ ನಿಮ್ಗೆ ಲಂಗ್ಸ್ ಅಲ್ಲಿ ಜಾಸ್ತಿ ನಿಮ್ಗೆ ಏರ್ ಕಾಣಬೇಕು. ಕರೆಕ್ಟ್ ಆಗಿ ಏರ್ ಕಾಣ್ತಾ ಇದೆ ಅಂದ್ರೆ ಓಕೆ, ಲಂಗ್ಸ್ ಸರಿ ಇದೆ, ಲಂಗ್ಸ್ ಅಲ್ಲಿ ಏನು ಬೇರೆ ಕನ್ಸಾಲಿಡೇಷನ್ ಇಲ್ಲ, ನೀರಿಲ್ಲ, ಮಾಸ್ ಇಲ್ಲ, ನಿಮೋನಿಯಾ ಇಲ್ಲ ಅಂತ ಅರ್ಥ. ಸೊ ಹಾರ್ಟ್ ನಿಮ್ಗಲ್ಲಿ ಕಾಣ್ತಿರೋ ಎಕ್ಸ್ರೇ ನಲ್ಲಿ ನೋಡ್ಬೋದು ನೀವು.
Sir, I'm sorry to interrupt you, sir. Please go in English, sir.
Okay, I thought all are from Kannada background. That's right. Okay, fine. So basically, see, what I mean to explain is, from the left side to the right side, in the top heading, you can see the air, which is the least opaque, is going to the highly opaque to the metal. So from the least opaque to the high opaque, you can see there is a difference from air to fat to soft tissue, bone and metal. So metal being the highest opaque. So in the X-ray, in the right side, you can see the hard borders, the bones, the ribs, the scapula, the clavicle, everything. So these are high opaque. That's why they are in white color. Whereas the less opaque air, which is the main part of the lungs, which is the work of respiration happening, that's why you can see the black opacity. So this is the basic thing. Okay, let's go to the next slide. Next slide, please. Yeah, so there is some technical aspects. Any X-ray to see, you have to first confirm the patient details. Still now, in many ICUs and what happens, the X-ray of a different patient is interpreted for a different patient. So confirm the patient details first, and there is something you should confirm whether it's a PA view, posterior anterior view, that we'll discuss later, versus anterior posterior view or lateral view. So there are three types of view. And coming to the third, exposure, how is the exposure quality, and the rotation, whether the patient while taking the X-ray has stood or presented parallelly to the X-ray beam, that is also important, and breathe. So whether the patient while taking the X-ray had a full deep inspiration or expiration. That next slide, yes. So 4 major views: posterior, anterior side, anterior, posterior, lateral, and lateral decubitus. So remember this. Where and all it is, the most important view which we all commonly use is the posterior anterior. Okay, next slide. So you can see here the PA view where the X-ray beam is coming behind the patient from his back, and the patient is standing firmly attached to the film where the beam is collected. So the rays is coming from behind, so it is called posterior anterior, and it is collected anterior. So this is the most standard view for all routine chest X-rays, and it is taken in full inspiration. So you can remember almost all of you would have got done X-ray once in your lifetime. So you will remember the technician telling, take a deep breath. Why? Because you have to take it, when you take a deep inspiration, the lung is expanded. So what are all the anatomical structures, what all the small findings will be more enhanced. So that's why you have to take a full inspiration, deep inspiration for every chest X-ray, because once the lung is filled with proper air, only you can interpret it. Okay, next slide. AP view. So the same patient, if we has an AP view, means what is happening? The beam is coming anteriorly. You can see in the left side, left part of the slide, the image, the beam is coming anteriorly, the image is collected posteriorly. So what happens? The anterior structure, that is the heart, means the posterior structures, which all is the heart, which is being enlarged. I mean, the same patient, same heart will look enlarged in a AP view compared to a P view. So that's why the view is important. So it should not be wrongly interpreted that he's having a cardiomegaly and all. So patient why do you do AP view when the patient is bedridden, when patient is too ill to stand or non-cooperative? So that is the point. And heart is at a greater distance from film. So appears enlarged because heart is posterior. Okay, next slide. So same as I told, PA versus AP view, same patient, you can see left side it's a PA view, right side it's a AP view. What is you can see the clavicle over the lung fields, whereas in AP view it is above the lung apex, scapula away from the lung fields, in AP view it is over the lung fields. So the main part is, the main, the difference, how to differentiate is the heart. You can see the heart is relatively enlarged in AP view. Same patient, same time, same place taken, but the change in view, you can see it's clearly, the first thing you notice is the same patient, but just changing the view, you can see the heart is enlarged because the rays are collected posteriorly. So all the posterior structures looks enhanced. Next slide. Okay, lateral view. Why we need lateral view? See, lung is a 3D structure. It's not a 2D thing where you can only see in the front. It has a 3D. It has a very deep lower lobe where the diaphragm covers up. So there is a lot of hidden spaces. So once you take a different view, the lot of hidden masses, hidden structures can be visible. Yeah, the slide is missing. Yes. So the lung lobes, mediastinum, and bony thoracic cavity are better visualized. So this is usual for lobar pathology, mediastinal masses, encysted pleural fluid, and basal consolidation, which is usually missed in an AP or a PVO, because what happens is the lungs are covered below this diaphragm in the posterior part. The lungs are big, the lower lobes are big, so it is below this diaphragm. So to see that, you need a lateral view, then only you can able to see this. Yes, next slide. Lateral decubitus view. So specialized projection to demonstrate small pleural effusions for pneumothorax. So what happens is there must be at least a minimum of 100 ml pleural fluid to be seen in a proper PA view, but you can pick up even as small as 15 to 20 ml in this lateral decubitus view. If you are feeling the patient yesterday was fine, today he is not feeling good, he is having some fever spike, you have a doubt, still the X-ray is looking normal in a PA view, you have a doubt this patient might be developing some effusion, some kind of pus in his lung, get a lateral decubitus view. Then you can easily pick up the fluid, because the view, the lateral decubitus view, make sure the fluid is seen out in this position. Next. See exposure, coming to exposure, overexposure on the over and underexposed on the right side. So adequate exposure, what it makes sure is intervertebral spaces are barely visible through the heart shadow. So if shadows, you can see the barely it should be visible. If it is not barely visible, that means you should go either to adequate, underexposed or overexposed. If it is too visible, means overexposed. If the rib shadows, intervertebral spaces behind the heart shadows are not visible at all, means it is underexposed. Very simple. So overexposed film, intervertebral spaces clearly visible through the heart shadow. Underexposed, intervertebral spaces clearly visible through, clearly actually not visible to the under shadow. Next slide. A rotation, this is very important. So what you must do is rotation. See, whenever the patient is standing straight to the film, if he is turning to the right or left, it is called right anterior oblique or left anterior oblique. So how will you determine it? You have to draw a straight line in the center of it, and you have to measure the distance between the clavicle and the middle of the trachea. So if that space is equal from the medial end of the clavicle to the mid of the trachea, so it should be equidistant. If it is not equidistant, if one side is more, that side is called right anterior oblique. If one side is less, that side is called left anterior. So basically you draw a central line axis, and from the medial end of the clavicle, you measure it. It's very simple. By seeing the X-ray itself, you can know. See, this should happen over practice. You should see a lot of chest X-rays. You should go up according to this point. Then only you will make a habit of interpreting all this. Otherwise, you'll just start seeing X-ray. You'll just see the heart and you say it is cardiomegaly, fine. What about the exposure? What about the rib? What about the rib fractures? All these things to see, you have to make it a habit of interpreting one by one from the beginning. Next. So as I said, once the patient has had a good inspiration, you can see the 6th anterior ribs are visible anteriorly. So you need to count anteriorly 6th rib and posterior ribs 10th visible. So anteriorly it starts from very beginning, 1, 2, 3, 4, 5, 6th rib should cut the hemidiaphragm. That means the patient has done a good proper inspiration during X. That you can see on the left side. If the same patient has not done a good inspiration, if has done expiration, you can see how the X-ray looks bad, and we start on antibiotics, do all the nonsense things just because the X-ray is done in a wrong way or we have interpreted it in a wrong way. So understand the importance of X-ray. This class is very important because if you are not taking the X-ray in a proper way and you're interpreting in a wrong way, unwantedly, you're treating patients with unwanted medicines and you're causing. So this is very important. So before interpreting X-ray, you should know what's the exposure, what's the inspiration, whether it's fine, whether it's not. If you have any doubt, repeat the X-ray or talk to the technician whether he has done properly or correlate with the patient's symptoms, whether you're not getting any correlation. If patient is absolutely fine, no fever, nothing, and X-ray is looking bad, you should have a doubt whether the X-ray is done properly or is it of a different patient. So this class is very important for you to understand and correlate clinically and not to make mistake, because these mistakes keep on happening in every hospital and every MOs do this, because I've seen it many of the times just for some small patch or something the patient is given because they're not correlating to the clinical. So you need to understand the inspiration part, the rotation part, which view, all these things, and you should correlate to the patient. Yes, next slide. So normal chest X-ray, how it looks. You can see a well-defined clavicle, no rib fractures, the trachea is straight, it's not deviated. The 6th rib is cutting the right hemidiaphragm. The heart border is well defined. The costophrenic, cardiophrenic angles are clear, and there's no foreign body in the trachea. Neither the mediastinum shifted to right or left, and well demarcated lung fields. Scapula is fine. So this is the normal chest X-ray. So in and out, not all the patients normal chest X-ray looks like this. There will be so many subtle changes, but okay, fine. There will be some patients might have some old TB changes. They'll be have some calcification. Still, they are normal for today's consideration. So you need to know what is normal to that patient. It's not normal is not a universal phenomenon. Normal to me is something different. Normal to a patient is something different. So you should in a healthy young patient who is not having any disease, any history, this X-ray you can take it as a normal chest. Yes, next. So interpreting X-rays, there is some mnemonic ABCDE, GH approach. So airway, A for airway, B for bones. So you can note down this: C for cardiac shadow, D for diaphragm, E for effusion, F for fields, G for gastric bubble, I for L. So while seeing the chest X-ray, you must see the airways, You must see the bone soft tissue, cardiac shadow, diaphragm, effusion, as I told, fields, the lung fields, gastric bubble. Of course, you can appreciate that. Hyla and mediastinum. Yes. Next slide. So this normal chest X-ray is self-explanatory. See, this is an imaginary surface anatomy, like how you should visualize the chest X-ray once you see and what all the organs comes beneath it. So this comes over a time of practice, and you should know just it's a general, what you say, anatomy where you should not forget and you should imagine the structures beneath it and appropriately enter, because this what is happening, it's a so complicated thing, especially in the mediastinum, hyla. There are a lot of vascular structures coming into place. So you can't exactly tell which structure, whether it's a mediastinal lymph node or a a vascular structure or a trachea, which is enlarged or which is compressing. So that time definitely you need a CT scan and all. But for your general understanding, you must know the beneath the superficial surface anatomy, what all the structures are. Next slide. Yes, about the ribs I told you. Yes, next slide. Yeah, lateral view also same thing. Where is the heart border coming? The thoracic vertebra, the scapula, hilar regions, the ribs. So you can see the costophrenic angle is much beneath the left side of it. The last labeling, costophrenic angle, you can see so beneath it is. From the anterior view, it's look much higher, but backside, the posterior recess is much lower. That's where we miss the effusions and all. So you must understand, by doing a lateral view, the view changes, the 3D structure of the lung, the understanding changes. Yes. Next. As I told you, airway, trachea, you can see the right and left main, the carina, which is separating the two main bronchus. So usually the trachea is slightly deviated to the right in all the healthy patients, but it should not be abnormally deviated. Slightly, that's why you find a lot of foreign bodies, getting in the right main bronchus. Next slide. Again, the right lung anatomy, where you see right upper lobe, how it's demarcated. So there are basically two fissures. One is the horizontal fissures and the oblique fissures that differentiates the right lung, whereas for the left lung, there is only one oblique. Next slide. Same way as I discussed left. So in right, there are 3 lobes, left 2 lobes. There is something called lingula, which is because left side there is heart, so body has to accustomized to it. So that's why the left lower lobe customized to the left middle lobe, and it has something called as a left lingula. It's a very small patchy structure. Next. So basically in chest X-ray, we can't say upper lobe, lower, because there is a lot of overlapping. So that's why they differentiate as upper zone, mid zone, and lower zone. So the first 2 ribs, we tell it as upper zone. Second to 4th rib as mid zone, and 4th to 6th rib, we call it as something called as a lower zone. So basically, when we are telling X-ray, when you are over a phone to some consultant telling, we must tell in the upper zone, mid zone, and lower zone. So in the mid zone, in the lower zone, still it can be in the middle lobe, but it might look like it is in the lower lobe. No, because there's a lot of overlapping structures. The segments overlap. The upper lobe, middle lobe, and lower lobe of the right lung is not exactly placed, horizontally. It's placed in a different symmetrical way, where the lower lobe actually is much higher and covering the lot of lower space, but it is the superior segment of lower lobe can come up till upper zone sometimes. Next slide. This is the cardiac anatomy. It's not needed in the chest X-ray, but for general understanding, to know the left heart border, right heart border, when there is a carpal nail in the right, when the heart border looks abnormal, or when there is mitral stenosis, or when there is cardiomegaly, when there is pericardial effusion. So to understand the structures, you should know this generally. Next slide. Same again, next. Next. Yeah, seal out sign. This is very important. See, seal out sign, why we call it a seal out means, it's basically for example, some incidents happens in one area, the collateral damage happens in the neighboring area, something like that. So if your house or some building or some gets caught fire. The neighboring structure also has some collateral damage. So something here also, what happens is the right upper lobe, ascending aorta. So if there is any abnormality in ascending aorta, the right upper lobe is looking abnormal. The right heart border, if there is any issue, the right middle lobe gets sealed out. Or the other way, if right middle lobe lesions, consolidation in the right middle lobe, the right heart border is sealed out. Same way, right lower lobe, there is some pneumonic patch, there is some lung abscess. The right hemidiaphragm is sealed out. The left lower lobe, left upper lobe first, the aortic knuckle, left heart border is sealed out. The left lower lobe, left hemidiaphragm, and the descending aorta sealed out. So you should understand that structure seal out the other structure, this structure seal out the other structure. It's as simple as that. Next slide. The cardiothoracic ratio, very important. You know, you should take the transverse diameter of the whole, chest wall, and you have to take it from the heart border. So the normal ratio should be less than 0.5. If the ratio is above 0.5, means cardiomegaly, means the heart is abnormally enlarged. Very simple. Next. Yes, cardiophrenic angle, costophrenic angle, as I told you earlier, you can see it is well demarcated, self-explanatory. The right costophrenic angle, left. So you must observe this for pleural effusion. If you are looking for pleural effusion, if you are looking for any heart border, any pericardial effusion, so these are the seal out signs. Next. Yeah, trachea and the right pulmonary artery. Yes, this happens when there is a pulmonary embolism. Sometimes, X-ray can be evident. You can see a cutoff sign, or there's a dilatation of the pulmonary artery. So for general understanding, this is there. But anyway, now we do a CTPA or a ventilation perfusion scan and only confirm. We don't rely on X-ray. Next. Mediastinal widening, yes, you can see here exactly the mediastinum width greater than 6 centimeter on erect PA view or 8 centimeter on a supine AP view. It is clearly demarcated. You can see the mediastinal width is greater, means it has enlarged. So abnormally enlarged. It should not be more than 4-5 centimeters. If it is more than 5-6 centimeters, means there is some mediastinal mass. Then the patient might require HRCT thorax to confirm where is the mass, what type of mass, everything, biopsy later. Yes. Next. Okay, mediastinal masses, yes. This, for general understanding, you should know the 4 T's: thyroid, thymus, teratoma, lymphoma, all these things. Posterior neurogenic tumors, extension of spinal masses. Middle, you can see the lymphadenopathy, aortic aneurysm, pericarditis dilated. Yeah, this is very important. See, why you might think in CT scans came into medical sciences because of this. There's a lot of hidden areas, even in spite of doing a very good high quality X-rays. You can't see so many structures, especially the lung apex. Ribs are often obscuring, especially beneath the ribs, it obscures. There is something, hilar vessels in the hilar obscuring the lung anteriorly and posteriorly. The hemidiaphragm, it's a big, like a road hump. If the road hump is so big, you can't see the other side of the road, something like that. So that is also obscuring, especially the left lower lobe, right lower lobe part of the lungs. And the cardiac shadow, the heart itself is a big blockage. So hiding a considerable amount of lung posteriorly. That's why you can see, though sometimes the patient X-ray looks fine, patient might be having signs of pneumonia, breathlessness, change in color. Then that's why the role of HRCT scan. But you should understand, not all patient requires HRCT scan, but if you should know this hidden areas where all the possibilities of a patch or a lung abnormality being revealed. Yes. Next slide. To sum up the inside out approach, you must know how to go about. Either you should go from inside out or outside inside. Next slide. The cardiac, you can skip this cardiac pathology completely. Next. Next. You can skip all this. These are the basic examples. You can just show it slowly. Next. So these are all the congestive cardiac bat wing appearance, curly B lines. Yeah, pericardial effusion, you can see the typical water bottle sign, the globular heart shadow, water bottle sign. It's No, it's a neat exam questions, all this CT ratio. Yes. Next. Yeah, pulmonary hypertension, you can see the previous slide. You can see there is a cutoff sign. You can see the hila enlarged and the pulmonary artery, there is a cutoff in the left side. You can see clearly. Basically, the patient's right side of it, right side of the patient's pulmonary artery, there is a clear cutoff sign. So prominent pulmonary outflow, you can see peripheral pulmonary versus right ventricle. Okay, next. So this is a question for you, right? This boot heart sign. Just tell me in the next class. Boot heart sign. What it is, you should tell me in the next class. Okay. Then
TOH.
pathology. What is that?
Tetralogy of palate.
Yeah, good. Very good. Good. Who answered it? What's your name?
I'm Dr. Alia.
Yeah, very good. Very good, Dr. Yes. Next slide. Yeah, white lung fields, black lung fields. So white lung fields, what all the opaque things will happen? Pleural effusion, consolidation, collapse, fibrosis, coin lesion, miliary lesion, lung mass, hilar lymph node, pulmonary edema, hemithorax. Whereas the black lung fields, when there is pneumothorax, the air is more. So the lung looks more black. Hydropneumothorax, again, there is air more. It looks more black. Cavitating lesion, there is a cavity, more air, more black. Emphysema, the lungs are stretched, more air, more black. Subcutaneous emphysema, definitely it enters the skin also, it look more black. Next. So these are some of the examples you can see in the left, pleural effusion, the left side of the image, this thing you can see the effusion is on the right side, whereas the right image you have bilateral pleural. Next. So how to detect minimal? I told you in normal chest X-ray, it should require at least 100 to 150, but as in lateral decubitus, even 10 to 50 ml, you can pick it up. Whereas in ultrasound thorax, you can pick it even 5 ml of fluid you can pick. Ultrasound thorax is now what we use to detect and find the maximum point of where we can put the needle for drain. Next. Consolidations, yes, you can see in the left side of the image, you can see there is consolidation, the left lower zones and mid zone. In the right side, you can see there is a consolidation in the right upper zone. And you should not get confused with the breast shadows. So right side picture is a female, so the breast shadows also might sometimes mimic, or so you should be a little careful. Okay, next. Again, same consolidation. Left side you can see right mid zone and right mid and lower zone. Whereas in the right image you can see in the right lower zone only. Yes. Yeah, collapse. Now what has happened? Can anyone tell to this thing, the left part of the image? What has happened? Can anyone tell? How is the trachea looking? Where is the mediastinum? What has happened? Yes, among 24, no one wants to answer. Yes, Dr. Alia, you only tell.
Pneumoperitoneum.
No, right side, what is the thing? Actually, where is the
Right
trachea?
side.
No, the left means
lung collapse.
In your vision, the left image I'm telling. In the left image, what has happened to the X-ray? Left sided means the left part of the X-ray. There are two X-rays. No, see,
Lung
trachea
collapse.
is being pulled to the same side. So collapse, yes, collapse or
Lung
there should be
collapse.
fibrosis. Yeah, collapse or fibrosis. That's why the trachea is pulled to the same side. Okay. What has happened to the right picture now? Right sided, right X-ray.
Hypotenuse. Pneumothorax.
No. Here there is collapse, right lower lobe collapse. That's why you can see the hemidiaphragm is shifted up. See, basically collapse means what? Tire puncture. Tire puncture, it will collapse. So the right pic X-ray, what you can see, there is right lower lobe collapse. There will be some mucus plugging. So lung has punctured. It has closed up and it has come up. That's why you can see that white consolidation. Okay, next. Yeah. Now, where is in the left pic, where is the collapse? Tell me. Yes, come on, tell. If you open your mouth, think only you can learn.
Upper zone, sir.
Upper lobe.
Yeah, right upper lobe, not zone, right upper lobe. While interpreting, you should tell upper zone, mid zone, low zone. But which lobe has collapsed? Most probably, you should use always medically, na? Should use the word most probably, sir. Right upper lobe has collapsed. Okay, in the right picture. In the right pic, which lobe is collapsed? Left lower. Very good. Yes. Next. So fibrosis is what basically lungs are getting hardened. Lung is something, you know, like a soft balloon, very soft. If it gets hardened like a wood, that is called fibrosis. It happens due to connective tissue disorders. It happens post TB. It happens with so many things. So when fibrosis happens both sides uniformly, the mediastinum trachea remains same. If it happens on one side only, then there is a change in dynamic. So what has happened to the left peak? There is bilateral diffuse fibrosis. That's why there is no gross change in the mediastinum or the trachea. Left in the right peak, there is some fibrosis started to happen, but not that much compared to the left. Okay, next. Yes, solitary pulmonary nodule. So these are some of the examples. Granuloma, bronchial carcinoma. You can see there is a solitary pulmonary nodule in the mid zone. Can you see all of you? Right mid zone, there is one patchy consolidation, coin lesion. So what all the differential diagnosis is all this: lung abscess, encystic pleural effusion, pseudotumor, pulmonary hematoma, iridocyte. So these are all IS stuff. Okay. So 40% of them are solitary pulmonaries are malignant. That's why you must observe every 3 months, 6 months. You must repeat a CT scan. You must see whether the lesion is increasing in size or not. Yes. Next. Yeah, miliary tuberculosis. So miliary means what? Millets, millet size. So many DDs can come. Sarcoid can come, TB can come, eosinophilia, histoplasmosis, pneumoconiasis, hemocytosis. Miliary mets also can happen if there is a thyroid CA, renal CA, breast CA, prostate, and osteostrate. See, basically, many times there is overlap of so many diagnoses. That time only we need to do a CT. We need to see the CT changes, or we need to do bronchoscopy. We need to do biopsy. All this comes into picture. But you must know the most common thing. That's why they put miliary tuberculosis as first. So in India, most common thing you have to think always. First is TB, then other thing. Next. Pulmonary mets, see how you can see miliary nodules less than 2, pulmonary nodule 730, pulmonary micronodule, pulmonary masses, how you can see the mets, you can see the masses there. Next. Lung masses, these all are the lung tumors, especially you can see in smokers. You can see the right side of the peak, how the trachea is being pulled because of the mass. And in the left side, even though there is mass, it has not affected the mediastinum or the trachea. It depends on how the hemodynamics affects the airways and the parenchyma. That way it shifts the mediastinum or pulls the trachea. Next. Hilar lymphadenopathy. Yes, this is one of the challenge. I said no vascular structures, so many things come, so we get confused whether it's a lymphadenopathy. So bilateral hilar lymphadenopathy, the most common causes sarcoidosis, lymphoma, then comes TB, then histopathology. So if there is hilar lymphadenopathy, our first diagnosis is sarcoidosis. We have diagnosed so many patients on chest X-ray without doing biopsy anything based on the X-ray because sarcoidosis has a classical presentation. Whereas unilateral, you have a chance of lymphoma, carcinoma, TB, and histoplasm. Bilateral is always sarcoid is something which is happening, something from the systematic autoimmune process kind of thing. That's why you get it bilateral. Whereas infections more tendly to have a unilateral presentation. That's why this cancer, TB, all these things can present more of unilaterally. But something autoimmune thing you should always present with a bilateral. It affects both the lungs equally. Next. Pulmonary edema, yes, you can see how the lung is congested. So that's why you should you can see even there is cardiomegaly. So you should confirm with echo, check for pedal edema, do a proper general physical examination, take a DUTL history. Then you should correlate with the X-ray. Never correlate X-ray directly. Always see the patient, take a history, examine the patient, then match with the reports. Next. Yes, there is something called as cardiogenic pulmonary edema, non-cardiogenic pulmonary edema. This I'll give you as a homework. Next class, you should tell me what are all the causes of non-cardiogenic pulmonary edema. Write down. Non-cardiogenic. There is something called as mnemonic, not cardiac. NOT CARDIAC. There's a mnemonic. You should tell all the causes of it. Cardiogenic pulmonary, everyone knows. EF is less, heart is congested, lungs are get congested. You give diuretics, they'll become better. Everything, or you give non-invasive ventilation, but not cardiac. Which is not, there is no cardiac cause only, but still they'll develop pulmonary edema. Why? There is a mnemonic, NOT cardiac. You should tell me the next. Okay, next slide. Yes, hemithorax, mediastinum pushed away from the opposite. This I said, now pleural effusion, large lung mass. What happens to the mediastinum? It's pushed away. Whereas mediastinum which pulls, whenever it pulls means there should be collapse, there should be pneumonectomy, there should be hypoplasia or agenesis. When is the mediastinum remain central? When there is pathology on the both the sides, consolidation both the side, pleural effusion, or combination of pathologies. Next. So these are the some of the example. Now you should tell left picture what has happened. Tell me, where is the mediastinum? Is it shifted to left side or is it shifted to right? What has happened? Tell me.
Shifted to
Left
left.
side.
Good, left side. So the pathology is on the right. There's something, a huge pleural effusion or a huge mass come pleural effusion, whatever. So it has pushed the trachea and mediastinum to the left side. What happened to the right pic? Right pic also there is a huge effusion looking on the left side, but why the mediastinum or the trachea is not shifted? Because there is something called as a dual pathology. I told you, not dual pathology. There will be some amount of collapse also. There will be some amount of pleural effusion also. It has neutralized. That's why it is remaining there. Okay, next. Okay, now tell me on the trachea is pushed or pulled to the same side.
Same side.
Yes, very good. So what can be the possibilities? Either fibrosis or collapse. Okay. What happened to the right pic? Same side or opposite side?
Opposite.
Same side. Same side. You can see the trachea is pulled to the same left side. It has been pulled. Right picture I'm talking about. So there must be some surgeries done or some, very gross fibrosis or something. Yes. Next. Next. Pneumothorax, yes. In the left picture, you can see there is a pneumothorax. There is high black lung fields. Whereas in the right picture, you can see clearly the lung border. You can see the lung border has been clearly demarcated with the pneumothorax. So which film you prefer, AP view or PA view? For pneumothorax, which view you prefer? Think and answer. Why? Wrong. PA view only, but with a full inspiration. PA view only, but deep inspiration. If it doesn't take inspiration, where will the air fill? We can't differentiate pneumothorax. Yes, next. So pulmonary cavities, the differential diagnosis, carcinoma, autoimmune disease, vascular infections, trauma, young. You can see where is the cavity now in the X-ray? Tell me. Which side? Which zone?
Right
Left
middle.
lower zone.
Left
Left
lower zone. Yes.
Next. Lower zone.
Next. Next slides, please. Yeah. Now tell me on the left pic, where is the cavity?
Right middle zone.
Yes, good. The right picture.
Right upper zone.
Right upper.
Right upper.
Right upper.
What it is called? What this cavity is called? You can see a fluid level. What it is called? It is called hydropneumothorax. There is a fluid also, there is air also with a cavity. So it's called hydropneumothorax. Next. Typical picture of a TB. Not all patients with TB come with this X-ray, but a typical active TB infiltrates, consolidation, cavity, mediastinal hydral lymphadenopathy, everything. Previously TB healed lesions also. Okay, next. Emphysema, proper COPD patient who smoked more than 20 pack years. When you say 20 pack years, he must smoke 1 pack of cigarette per day for 20 years. So that will definitely cause emphysema up to some extent. And it has happened. You can see the anterior rib, 7th or 8th rib will cut. Instead of 6th rib, because the lung is expanded, hyperinflated, emphysema, 7th or 8th rib will cut. That's what you can see. Next. Subcutaneous emphysema, you can see outside the chest wall. Once you start seeing the air lesions, then you should understand there is subcutaneous emphysema. Very clearly demarcated in the right sided picture. Why this happens? Why the subcutaneous emphysema happens? Can anyone tell? And what is the treatment, you know?
Rib fractures.
Yes, rib fractures. When you put ICD, when you don't dress it properly, stitch it properly, sometimes spontaneously. But what is the treatment to do? Think and tell.
Skin.
Physics. It is physics, second year physics. PUC.
Spirometry.
Spirometry wise. You know, basically what has happened, air is filled in the subcutaneous tissue. How will you take it out? Physics, I'm giving a hint. I'm giving a hint. Second year physics. +2 physics. You would have read, forgotten.
Chest tube
basically,
insertion.
No, chest tube is already inserted, still it is there. So what you should give high concentrated oxygen.
Oxygen, yes.
Why? Because then diffusion happens, because the subcutaneous air, whatever is filled, is the atmospheric air. It is having 21%. When you give high concentrated, when you give 100% FiO2 oxygen, it gets diffused. There is exchange. Then the air from the subcutaneous tissue comes to the lungs. Got the point? There will be exchange of gases. That time the air reduces. So whenever a patient with ICD, everything you have done, still the patient is getting subcutaneous, you should give high concentrated oxygen. Then due to cross exchange of osmosis, okay. I think it's done. Any doubts, questions you can ask?
Any doubts, doctors?
Hello.
Please feel
You're
free.
fine.
This is the question and answer session time.
Hello.
Yeah, tell me.
Sir, you said the rotation between clavicle and mid trachea is what we have to find, sir. The distance between the.
No. See, when you get the X-ray, take the mid-axis from the trachea, measure whether that axis is equidistant to the medial end of the clavicle of the bone.
Okay.
If he is rotated, this will be shortened, right?
Yeah.
So it is left anterior oblique. If his patient is rotated this way, it is right anterior oblique. So if he is straight, only both difference will be equal, no? That's it.
Okay. Then we had said you told one question now, sir. What was that? About non-cardiac something.
Not
question.
cardiac, it's a mnemonic. You have to read and tell me. Not cardiac, pulmonary edema. The causes of pulmonary edema, which is not related to heart.
Okay.
You tell me in the next class.
Okay, thank you.
Anything else? So you should go through the PPT again. You should start interpreting X-rays from the basic thing, approach, rib, scapula, everything, clavicle, heart border, costophrenic, cardiophrenic, every angles HILA, should make it a habit. Every X-ray you see should make it a habit to interview. Then only you'll get into this. And never forget there are so many hidden areas. That's why always correlate with the patient. If patient is not fine, if you're failing, you should go for a CT scan.
The costophrenic and cardiophrenic angle, if change is there, how to identify and what all that indicates?
Yes, you see a normal chest X-ray first. Go through a normal X-ray, then see the abnormal chest X-ray. You'll find it should be well demarcated. The costophrenic, cardiophrenic should be well demarcated. If it is not demarcated, means there is something there.
To differentiate between a cavity and a lesion or something like that.
Yeah, cavity is well demarcated. Na? There is a round borders that we showed in this thing, na? The slides. Basically, cavity can be due to meds. There in the cavity there can be air fluid level, that is hydropneumothorax. Cavity there can be aspergillus ball. So there are so many differential diagnoses for that also. That also one slide we had. Done? Can we close the session? Hello? Can the admin respond?
Yes, sir.
Okay,
We
thank
hope no other questions are there, doctors.
Yeah.
Okay. We like to thanks to Dr. Chetan sir for giving this much of information on chest X-ray and APG. Thank you very much, sir.
Okay, thank you.
ABC next class, sir.
Hello.
Hello, we have not discussed about the ABG, right? This in this class.
Hello. Can you hear me?
Yeah, we can able to hear you, but we did not discuss anything about the ABG in this class.
Okay, give me 1 minute, ma'am. Hello. Hello.
Hello.
Hello.
ABG will be conducted in the next class.
Okay. So when we'll be having that?
Very soon we will be having. We are going to inform you in advance in the group.
Oh, okay. Thank
That
you.
also we have to pay, sir.
Hello.
That time also we have to pay.
That we will confirm you, ma'am.
Okay.
Yeah. Thank you. Thank you all.
Thank you. Thank you so much.
Thank you.
you.